I'm Joan Nolker. I'm one of the emergency medicine faculty, and I'm also one of the assistant program directors for our residency program. And then I do some work with the medical school as well, teaching preclinical med students, including part of the IPE course. In MD, generally speaking, it varies depending on which specialty you're in and where you're working in the hospital or in the outpatient setting, but we are usually the ones helping to coordinate the majority of the care on our care teams. And so our personal focus is on figuring out what are the major health issues that this patient is having, kind of figuring out what realms those will fall into, and then figuring out what resources that we need to start employing to both diagnose and treat whatever health conditions that the patient has. So, making the diagnosis is usually step one. So that involves doing additional testing, which might include getting other specialists involved to try to figure out, why the patient is having the symptoms that they're having, because that's why they come to us, because there's some sort of condition or symptom that they're experiencing, and then to diagnose. And then when we start thinking about treatment, sometimes that is things that we can do on our own, like prescribing medications, but pretty much everything that we're going to do is going to involve some other subspecialist or some other care provider. So if it's medication based, then we're going to need to get pharmacy involved. If they need some sort of therapy, or whether it's occupational or physical therapy, we'll get those groups involved. We may get other physicians involved from different specialties if they have a complicated issue that requires a lot of specialists. So generally speaking, that's kind of our basic role on the team. So they can work in a whole variety of settings. So the biggest differentiation would be some people are primarily inpatient, meaning working in a hospital itself, versus outpatient, meaning working in a clinic or some other setting that's not in a hospital. So that would be the kind of main difference. And then when you're talking about, and then I guess the other big division within for MDs would be the separation between medicine and surgery. And so some people who are in surgical-based specialties are going to be spending, whether they're inpatient or outpatient, are going to be spending a good chunk of their time in the operating room, so doing procedures and performing surgeries. If you're more medical-based specialty, then you're not performing as many of those procedures. You don't do surgeries, and both of those different subspecialists or kind of groups can be inpatient or outpatient. And then there's a ton of variation within that. So just kind of very briefly, most of the settings within academics are going to be largely hospital-based. So if you're at a university setting, a lot of the work that's being done is being done in the hospital, although there's a lot that's done outpatient as well. My setting is one of the ones that's a little different and unique. We kind of bridge the gap a little bit. So emergency departments are pretty much by definition always attached to a hospital, but the patients can come in and then be discharged from our setting, which then is almost more of a clinic type setup where they come in briefly, we help diagnose and solve a problem, and then discharge them home, or we can admit the patients and then they become almost like an inpatient individual who then will stay in the hospital and move to a different area. So generally speaking, kind of inpatient versus outpatient, and then medical versus surgical would be the biggest divisions. For us, having interprofessional teams is just an absolute necessity. There's no way that we could function in the emergency department in isolation by ourselves as physicians. It just wouldn't work because there's too many things to know. Medicine has become much too complicated for any one individual professional to be able to manage all the things that need to be managed. So the closest group that we work with the majority of the time would be our nursing staff. So we're pretty much on the same page with them the whole time. There's plenty of skills that they have that I do not have that I need them to be working with us. They're the ones who are spending the majority of the time at the bedside with the patient, so we really rely on them they have fewer patients than us, so they can keep much closer track of them, whereas I'll have many more patients, and so I rely on them to give us updates on patient conditions. We have a pharmacist in the emergency department most of the time who is able to assist with some complicated medication dosing when that's needed. We work with technicians and respiratory therapists on a daily basis and use their expertise for all of our patients. We have a physical therapist who's in the emergency department, not 24/7, but a good chunk of the time, and then some other professionals that we often don't think about as much in the direct care, but for us, especially in the emergency department, are completely essential. So our social worker, I would die without that person in our ED. They're completely necessary because we have a very complicated patient population who most of their problems are socioeconomic driven issues and issues of poverty, and so having assistance of social work is very useful, as well as our case coordinators who can help figure out how do we get these resources, how do we get an oxygen tank for this person who doesn't have one, and they can help coordinate that. I have zero idea how to do any of those things. And then some of the other groups that we work with that are a little outside of what we usually think about in IPE are all of our pre-hospital providers. So I work every day with our paramedics and EMTs and people who are doing medical care outside of the hospital, and that's a totally different setting that I didn't even mention before, but there's a lot of medical care that happens even before the patient gets to you in the hospital. And then other groups in the community as well. So just last night I had a patient that was a victim of violence, and so we actually were working a little bit with the police who came in to have questions about how is the patient doing, and so we interact with a pretty huge variety of other professionals.